When I speak about the COVID storm, I am oftentimes not referring to the cytokine storm in severe COVID 19, but I'm referencing the fact that when you have a situation where you have a population who is immune primed or an individual, getting recurring infection can be very, very serious. And this is what I mean by the COVID storm. Recurring COVID infection along with COVID vaccination and immune priming. And so I essentially expect this to happen in highly vaccinated regions. The question is it just a hypothesis? Is there any evidence to show you that this is actually happening and has been happening for a long time, but is not given the attention that it needs to be? So, what I'm going to be doing today is that I'm going to be taking you through a case. And this one was just recently published. And what's interesting is that the data is just starting to come out. And in this case here, they were looking at mural thickening of the coronary arteries in a COVID 19 patient. It was published online on the 23rd of September 2024, but it's only recently been published in the journal in 2025. And so this is why we're just seeing it. But in reality, this evidence has been there since 2021. It just takes a while for the research to come through. So what I'm speaking about is very often way ahead of what you know. So for some people, it sounds like misinformation. I'm just making stuff up because it's making people anxious. No, I have just extrapolated the science and I'm using the science to guide what's happening because it's predictable. Once you understand how this works, everything makes sense. So let's get into just a few simple principles with regards to the heart. You have to understand this in order to make sense of what it is that I'm talking about. Here we have an image of the heart and the blood vessels around the heart. And you can see here that you have in blue represents the veins coming down from the head. So the head is up here, the neck is here, and these veins come down to the superior vena cava, which then goes into the heart, returning blood from the top of the body. And there's also the inferior vena cava coming up here as well. The blood then goes into the heart, is pumped through the lungs, and then once it's pumped through the lungs, it is then coming back to the heart to be pumped through the aorta around the body. And that's essentially how the body normally works. And so this is the pulmonary trunk where the arteries go to the lungs, and then they come back and then they pump the blood out through the aorta. And then on the surface of the heart, you have these blood vessels, and these blood vessels supply the muscle in the heart, and this is what keeps them going. If any of these blood vessels get blocked, that's when somebody can have a heart attack. That's the basic point. That's where we're starting from, just so that you get a grasp of the science. So let's get back to the case, and you'll understand what I'm talking about. And as a reminder, when I say the COVID storm, this is what I'm talking about. Spike triggered autoimmune response mechanism means that there is already immune priming, and then on further exposure of the spike protein, oftentimes with infection, you can then get quite significant autoimmune responses. So that's what I've been predicting since the middle of 2024. And that's where I came up with the concept of this COVID storm. But again, you may ask, is this just purely hypothetical? Watch this. In this case here, mural thickening of the coronary arteries in a COVID-19 patient. The first thing I want you to notice is the date on this first scan, 6th of December, 2021, then February 2022, and then January 2023, and then you had the publication. So the point is that we're talking about a patient from 2021. Now, it's an 80-year-old man. He was admitted for SARS-CoV-2 infection, and he was treated with dexamethasone. standard in terms of treatment for severe COVID-19. It's a steroid. He was fully vaccinated for SARS-CoV-2 before the infection. And the only reason that he was referred to the cardiology clinic was because his ECG suggested an old heart attack, myocardial infarction. And then when they did an echocardiogram, it showed that there were no wall motion abnormalities, but a mass in the right atrium. Okay, so let's just pause there so that you understand what I mean. Well, in effect, he's 80 years old. He came into hospital with a COVID infection for which they treated him with steroids. After treating him with steroids, they happened to notice during his admission that his ECG, that's the electrocardiogram, had some abnormal patterns that were suggestive that he may have had a heart attack in the past. And so, as a routine, they referred him to cardiology. So it's important to note that this was a routine referral. It wasn't an emergency referral. It was just a routine referral that they asked the cardiologist, could this guy have had a heart attack? So they arrange an echocardiogram as a routine because what they're looking for is that the echocardiogram sees live motion of the heart. And so if you have an area of the muscle that's not contracting, that's what we call regional wall motion abnormalities, meaning that it's not contracting normally. It could suggest that that area is scar tissue, and it would support the diagnosis that he had a heart attack. That's where we're starting from. So what then happened next? So as they go along, they then went on to do a coronary CT angiography, okay? And again, let me pause here so you understand what we're talking about. So what we do with an angiogram is that we then put a needle or a catheter into an artery, and then we, into a vein actually, depending on what kind of angiogram you're doing. But if you're into an artery, if you then inject the contrast, it then lights up the artery so that you can see what's happening in and around the heart. You can do an angiogram of many other tissues, not just the heart. You can do it of the brain, you can do it of the kidneys. And so this is a standard procedure that is done very often. And so they sent him for this investigation here, and it excluded a mass in his right atrium. But it demonstrated that he had thickening of all the coronary arteries and the ascending aorta and the arch of the aorta. Okay, so again, let's pause here. Make sure you understand what we're talking about. So what they mean is that when you look at the heart, like you have here, they saw inflammation of all the blood vessels, the arteries around the heart, the proximal parts, that means the top part where it's connected to where it's coming from, inflammation into the arch of the aorta, and all of these arteries out here as well were inflamed. This is very, very unusual. So this is why it ended up as a case report, because in reality, this is not something that we would normally see. But credit to them, they were looking and they found problems. This is part of the issue, is that if you're not looking for problems, you're not going to find them. If you expect problems to bump into you, maybe that's why people are not seeing some of the issues that are going on. Let's get back to the case. So they found that he had dilation of the right coronary artery. It had an aneurysm. And then they did additional analysis. Now, this was very interesting. They checked his immunoglobulins, IgG4 levels, and these were exceptionally elevated. 7.86 grams per liter. It's normally not higher than 1.3. So that's about 6 times higher than normal. And it had associated with it, well, it was technically an associated vasculitis, inflammation of the artery, and periarteritis, inflammation of the arteries around the heart as well. And they noticed that his pancreas was shrunken. So they thought that this was IgG4 disease, And that's an important term, this IgG4. You've been hearing a lot about it. And IgG4 is not a typical antibody. It's what we would describe as a tolerant antibody. What that means is that you have four IgG classes, 1, 2, 3, 4. 1 and 3 are antibodies that help your immune system to attack stuff. If they stick onto it, it causes the immune cells to target it. IgG2 is kind of one very rarely seen too much. We don't do too much about it. But IgG4 is more like what happens with beekeepers if they're stung all the time by bees. If you then have that kind of pattern, the body goes into tolerant mode and it says, stop reacting to the bee stings. And it does this by IgG4. So when IgG4 binds to the bee sting venom, the body will know, okay, don't worry too much about it. We've been seeing this pattern occurring, especially after mRNA vaccination, COVID vaccines, where they produce very high levels of IgG4, up to 45% of people, if they have been mRNA vaccinated, can have IgG4 levels compared to only about 1% in the normal population. So this is quite significant and very unusual when we think about what happens with a normal vaccine. So the minute you see IgG4 in association with COVID and vaccination, whilst it could be IgG4 disease, which is a separate autoimmune disease, you would have to wonder if this is related to the COVID storm. Now, when you look more clearly, it's difficult to explain all of these pictures, but essentially it's demonstrating what happened with the heart. And over time, you can see it was big here, it's getting smaller here. And that's because they treated him with immune suppression. This represents a PET scan, and it's showing very high lighting up of the heart here, which suggests active inflammation. The heart doesn't normally use glucose, so when you see it bright like that, it would very much suggest that this is a problem. And you can see here as well, very high uptake in the heart, very similar patterns to what we have seen as well in certain vaccinated cohorts after vaccination. So these patterns are all there and have been there for a long period of time. Luckily for this gentleman, he was then put on steroids and he was immune suppressed. And as you can see, over the next few years, he continued to do well. Why is this important? It's important because if the COVID storm is not understood, if it is overlooked, if that man had not been treated, if it hadn't been diagnosed, if he hadn't been put on immune suppression, he probably would have continued to deteriorate and would most likely, not necessarily absolutely, but most likely have gotten very sick and or died. That's the reality. The COVID storm is very subtle and it's not going to jump in front of us. It has to be looked for. The question that I am trying to figure out is, how do we know who is affected? Because as you can see, this man didn't look particularly unwell. That's what makes it even more worrying, because they don't necessarily look unwell and have this significant inflammatory process going on. How do we address it? What do we do? How do we get around the problem? The hope we have is that as things are changing in the US in terms of the scientific community and the leadership, hopefully we're coming into a period of time where people will stop running from difficult questions, but try and answer them. Face the reality. Look at the implications of what happens if you have immune priming and recurring infection. This is serious for any disease. If this was happening with measles, you would still be worried. The point is, we are in uncharted territory, and we need as much help as we can to figure out what is going on. Thank you.